All right, here we are. I believe we're live on Facebook now. So thank you to those of us who are joining us, and thank you to our two panelists here today. They're going to introduce themselves in just a minute, but in case you're not sure where you are, this is the Center for Pharmacy Practice Innovation's Facebook Live, The Struggle to Sleep. We're going to be chatting about insomnia, sleep quality, and all things that go along with it from a pharmacy lens and a cognitive behavioral lens. And my name is Madeline. I always forget that part. Thank you for being here. I'm the program support assistant for the Center for Pharmacy Practice Innovation. So if you have any questions as we're going throughout this conversation, please feel free to drop them in the chat on Facebook, and we'll get to them hopefully. So without further ado, I'll let y'all introduce yourself. Dr. Krause, if you don't mind kicking us off, that'd be great.
Sure. So my name is Erika Koss, and I am a current associate professor at the VCU School of Pharmacy. I've been here since 2017, and my background is in geriatrics as well as psychiatry. And I think part of the reason you all asked me to join you today is I have authored the Insomnia book chapter for our board certification in psychiatry for over 6 years. I did pass the torch recently, but I've also had opportunities, I'd say, to speak nationally at pharmacy meetings on insomnia and other sleep disorders as well.
Great. Thanks for being here today. We really appreciate it. And Dr. Ray Barczyk, would you introduce yourself?
Hi, everybody. I am glad to have been invited here because this is a passion topic for me and my work. I am a professor in the Department of Psychology at VCU, specifically the clinical psychology program. So I train future psychologists, and my research work has largely been, a good part of it has been in behavioral treatment of insomnia. I've been part of a growing focus on this treatment that I look forward to telling you more about. And I also have a private practice where I provide treatment for insomnia for a small number of people per week. And that's just a side gig, so I got to keep it limited. And I've worked a lot with Erika. I started at 2016, Erika. So we're oh, I'm sorry, 2006. Okay, I'm way by, here at VCU. So, and I work on the medical campus quite a bit as well with Sleep Center and other sleep interested docs.
Excellent. So, well, we'll just jump right in if y'all don't mind. Let's start with some basics. How much sleep is needed for the average adult? Dr. Krause, I'll let you kind of take that and break it down by sleep stage, if you don't mind.
Sure. And I think it's always a great question. I love to always ask the audience how much sleep they got if we were in a classroom setting, because nobody ever gets the correct answer. I think everybody shortens themselves from sleep, but ideally adults should get anywhere from 7 to 9 hours of sleep per night, which is where we come up with the magic 8 that you always hear everybody talk about. Younger children need much more, and interestingly, as we age, sometimes we don't need that full 8 hours. So like older adults might need a little bit less. And we're going to spend usually the beginning of the night in our earlier like stage 1, 2, and 3 and non-REM sleep, and then as the night progresses, we actually spend more time in REM sleep, which is why it's really important to get those later stages of sleep, because you get more restorative sleep.
Yeah, definitely. That I can definitely tell when I've kind of cut my sleep short, and I guess that's what I'm cutting off. What are some, you mentioned briefly, but what are some of the downsides? I'll let you take this one, Dr. Ray Barczyk. What are some of the downsides of not getting enough sleep? And is it true that you can't truly catch up on sleep?
Okay, that's great. Good place to jump in. I like what Erika was saying. The only thing I would add to that is the mistake made by people that are having sleep problems is they are over-focused on the adding up their sleep and using that number to judge how well they're, how much sleep they're getting, when in fact, if you have fragmented sleep in pieces with wake ups in between, the quality of the sleep goes way down, and quality in general is more important than quantity. And what I mean by quality is compressed sleep that's non-fragmented. And, I have a lot of people I treat who are getting fragmented sleep, and maybe it adds up to 6.5 hours or 5.5 to 6, and by the time we finish treatment, we might only have them at 6.5 or 7. And they are feeling fantastic because they've taken broken up sleep and turned it into high quality sleep. So that's an important caveat. Also, what you asked is important. What happens when you impair, when your sleep is impaired and not fully refreshing and restorative? Well, there's physical and psychological things that happen. Starting with the psychological, because that's what bedevils most people. We've got the, impaired tolerance of other people, impatience, lack of focus on and ability to achieve goals, cognitive fuzziness, a general tendency that we're feeling that we're feeling. There's a hyper arousal we can talk about later that tends to happen to people who are overtired, just like we say about kids who are overtired. They act agitated. And so, they've passed, their sleep need is high, but they're not sleepy yet. And so they're up too late and they're agitated. We're kind of the same way when we're sleep deprived. So yeah, so you've got all those psychological side effects, mood as well. And then it can trigger anxiety. And then the physical ones are a little bit more elusive, long-term, and build up over time. Sometimes people are over concerned. Chronic sleep deprivation is gonna, mild, is going to affect their health. And that's probably true, but sometimes folks over worry. I treat people who are worried about, who are in their 20s. I got a young lady in her 20s that I treated last year who was sleeping badly, but it was partly driven by her fear of getting dementia later in life because she had the genetic risk for it and had read and understood, very smart person, that, poor sleep can contribute, and it does in a very small way, to dementia outcomes. We're not exactly sure, but it's a very small factor compared to a lot of other things that contribute. So sometimes people are preoccupied, and that's part of their insomnia. They're preoccupied with the health outcomes. So I try to be careful about, saying, yeah, it's important, but it's one of many other factors.
And I agree with you. I think that's something to bring up, but it is also something I think we talk with our students and patients about. Good sleep is also important to reduce your kind of cardiometabolic concerns later in life, because we do see increased obesity and I'd say heart concerns when people are not getting enough sleep. My understanding, if you do not get a full night's sleep, I think less than around 4 hours, it's almost like driving impaired, as if they had a drink of alcohol before getting in the car. So it is really important to make sure we do get adequate sleep from that standpoint as well.
Yeah, that sometimes people call that core sleep. I hear the number 4 to 5 hours as being, enough to, prevent really negative outcomes like you described. And I forgot to answer the question, Madeline, about what can you make up for lost sleep? Well, thankfully we had some ambitious high school student in California who did the quintessential experiment with the Stanford psychologists and sleep center, where they monitored him as he over several weeks as he tried to break and did break the record for staying awake. It was, I think, 12 days or something like that. But the takeaway from that we all learned a lot about is that when you recover, you do need a little more sleep, recovery sleep. However, the recovery sleep is a whole lot less than the missed sleep. And that's because the brain will alter your sleep stages to give you a lot more of the rich and restorative sleep during the recovery process than you normally get. So deep sleep is essential for physical restoration, and your body takes a healthy portion of your time if you're recovering to give you deep sleep, more REM sleep as well. So our bodies are built for resiliency when it comes to sleep, because it's always been part of the human condition to have disruptions happen.
Yeah, that leads really nicely into the next question I had, which is, what percentages are we shooting for with those different sleeps? If we're sleep cycles, if we're not obviously trying to catch up, and if it's just a normal night, how much time should we be spending in each stage? And Dr. Krause, you look like you were ready to take that, so why don't you go first?
I was gonna jump in with something else, but that's fine. Usually earlier in the night, I want to say about 90 to 120 minutes is what you spend in your first sleep cycle, and you go through that usually 3 to 4 times over the course of the night. That's why we see that kind of 7 to 8 hours that we were talking about. I don't know if Dr. Barczyk wants to expand upon that.
I will. Okay. Yeah. So here's my quick. I'm so used to talking to patients and giving them little thumbnail, quick picture of what their sleep is like, because our sleep IQ in the general population is abysmal. Even in healthcare professionals, sad to say, we haven't caught up to the science. And then the general public, it's astounding how much people know about genes and heart and immune system and so forth. And then sleep, they know about, a few kernels of, and that largely happens because, 3/4, maybe more of the population have great sleep, and they don't have any problems with it. And so they've never paid much attention to it. So we got a lot of bored audience members when we try to talk about sleep, and it's not going to make it into the media necessarily, but the secrets of sleep are fascinating. And I taught a little seminar on that. And so here's my quickie on the stages. So just like you were saying, Erika, the 90-minute cycles, we have those through the night. So that's one way that sleep partitions itself and organizes itself. And each of those 90-minute cycles is REM, non-REM and REM. And as the night progresses, the REM part gets larger and larger, so that after the second half of the night, and especially that last cycle, your sleep is characterized by a lightness, because REM is very close to wakefulness. So you wake up briefly, momentarily, you form memories, you can kind of remember parts of dreams, some people, not everybody. And you're more easily disrupted. You wake up and start thinking about the day and go back to sleep. You're a lot more cognitively activated during REM. So that's one thing to keep in mind. So the other interesting thing is that the sleep is powered by adenosine. We won't have time to get too deep into the weeds, but in the first half of the night, our drowsiness, and the second half of the night, circadian system, which is measured by our melatonin and drop in body temperature, takes over and uses a new system to sustain sleep through the night. So we're going to find a little transition, and that's where a lot of people's sleep goes awry at the midpoint of the night if they have insomnia. So those are a few thoughts.
And I think you bring up a good question too. When we're evaluating people to treat for insomnia, I think people use the umbrella term insomnia, but really we want to know what is their issue. Are they feeling like they didn't get enough good sleep? Are they feeling tired despite adequate sleep? Is there difficulty falling asleep versus, as you just mentioned, are they waking up in the middle of the night at 2 o'clock in the morning and having a hard time getting back to sleep? And so those of us who work in the sleep space, there's a lot of different outcomes we're looking at, and depending what those complaints are, can also help us really determine which treatment we want. The one other thing I just wanted to throw out there though, which I think we're going to get into more non-farm, but it is important to have like a typical, I usually go to bed around 8 or 9 o'clock at night and I wake up at the same time in the morning. I feel like a lot of our college students think, going back to can they catch up on the weekend, they shorten their sleep during the week and then are like, oh, I can sleep until noon, which is not a healthy practice. They really want to be going to bed at the same time every night and waking up at the same time every morning. And I think cell phones have really impacted people's sleep, and people don't realize how much blue light comes out of those screens. Sometimes it's enough to trick your brain to thinking that it is still daylight outside, which is why people have a hard time falling asleep. But I'm sure we'll talk more about that. So.
Yeah, that's probably a good time to take a step back and talk about the different kinds of problems, if you guys don't mind. So yes, as we get into treatment, we got to be mindful of what the target problem is. So let's start with the most common sleep disruption is which maybe 30% of the population has, is a periodic a brief episode of impaired sleep, usually triggered by something like travel or a worry or job change, a relationship change, a speech the next day they have to give at work, and on and on it goes. There's 30% of the population have that kind of acute insomnia that comes and goes in a few days, and it's terribly annoying, and has a effect on functioning the next day and so forth. And in my mind, this is the best use of pharmaceuticals is for this kind of insomnia. We will get into that in the near term, shortly. Now, the other kinds of insomnia are the other kind of problems. And one of them is chronic insomnia. That's more like 5 to 10% of the population. And those are the people I work with that need a behavioral treatment. They've had the problem for years, 3 days a week, maybe even months. I like to catch them just a few months into it, I should say, but many times I don't see them until they're 2 years down the road or 3 years down the road. And it might have started with the same kind of precipitating factor that acute does, but it just morphed into a different animal. The original problem goes away, and most people are like, wait a minute, my pain is gone, my job is going great, the trip was already 6 months ago, my kid was born 2 years ago, and that's when it all started, and these things went away, and my sleep never recovered. So those are the kind of folks I work with. And then a third category I would say is folks that are trying to optimize their sleep. So I know some of you out there are just sleep curious because it's vital to your functioning and you want to optimize it. And so some of the stuff we're talking about, and I'll try to point that out when we venture into this territory, is how to improve and enhance your sleep around the periphery if it's not a major health problem for you, but you just want to optimize it.
Yeah, thank you for that. Why don't you go ahead and share a little bit more about how we can make our environments more conducive to sleep?
Okay, is that me? I'm up. Okay, good. I don't have my chart in front of me because I didn't print it, so I got to toggle back and forth. So the environment is very important. We're all conditioned to sleep is the most conditioned thing in our whole human existence, some would argue. And you see this in every culture and every point in history, that there's a series of rituals, a piece of furniture, a room, and so on and so forth, that all gets attached, associated with the falling asleep process and the flipping of the sleep switch. And we intuitively know that, so we arrange our living spaces and our lifestyle around that, that pairing of novel stimuli, the bedroom, bed, and pillows and so forth, and closing our eyes, darkness, reduction in sound. We pair that all together to make sleep. Now, the problem we run into sometimes is we live in a capitalist world where marketing is king, and every company out there knows there's 30% of the population with some type of sleep complaint, and that's a huge market. So they're continually trying to promote some kind of new pillow or new blanket. The heavy blanket is one of the ones that I like to chuckle about. And so we get this cacophony of marketing to sleep. And by the way, pharmaceutical fits in there as well. It's a super high profit product. So that's part of the cacophony that prevents me from getting the people in my world getting the word out on behavioral treatments. But the marketing for bedroom stuff is incredible. So I try to leave that part out of my work because I'm dealing with people who've been already through hundreds of changes to their sleep environment, and also bought a lot of very expensive products. But generally, yes, the quiet and the routine, of course, is the big one that Erika pointed out, and then pairing your bed space and bedroom with sleep. And not everybody can do this because maybe their bedroom is their sanctuary for other things like work and so forth. But ideally pairing it in that way. And there's adjustments you can make about, I just had a guy I treated who had to spend his evenings in one room, that his wife was in another space. She had different sleep habits and needs and a disability. So his evenings were spent in a bed, in his bedroom space. And a big breakthrough for him was to move his activities into a chair and stay off the bed all night. And he thinks that really helped him turn his insomnia around. So, very much so, the training of sleep to entrainment of it is the word we use technically, to physical space and so forth, is critical.
Yeah. So just to kind of summarize what I think I'm hearing, we have these like nighttime rituals, and those can be helpful to a point, but buying the latest product probably isn't going to help if we have a chronic issue. Would you say that's right?
That's a good summary, yeah. And temperature, there's an argument to be made that a lower temperature is sleep facilitator. There's a Stanford sleep researcher's got a new book out, and so forth, and it's on his list of top 3 things you can do. The other ones being stuff we're talking about, but he zeroes in on the, your body temperature drops as part of the circadian cycle. So, facilitating that by taking a warm bath before night to really heat you up, and then have that drop before you go to bed, to have that drop occur, has long been, suggested as a tool for potentiating the temperature drop, but also, having the room nice and cool is the other part that has been argued as a tool. Some point in the future, our technology will be such that we will get a graph of our core body temperature, and that is the best measurement of entrainment, how well your sleep is entrained to the circadian clock and how well your circadian system is helping you sleep. And it's just a very hard thing to turn into a product that can even be used in healthcare. Research only so far, so you need some kind of capsule that you're going to swallow and then excrete, to be polite about it. and it's going to graph your body temperature. Also, there's a anal measurement tool that's very uncomfortable to use. So we got to make some progress there. But I think feels for certain somebody's going to figure that out, and one day we're going to be able to look on our watch and see our core body temperature ups and downs, and we'll know how well entrained we are. And we'll see progress when we do better at entraining ourselves by sleeping on a regular schedule and so forth.
I could see that coming in the near future, definitely.
Yeah.
Especially since we can see, the sleep stages that we have on our watches now as well. I don't know quite accurate that is, but
not quite accurate, but not terrible and getting better. At least it tells you when you were sleeping
sure.
or not fairly well these days.
Sure. So just to jump around a little bit, Dr. Krause, could you kind of bring the pharmacist perspective in, and then I want to hear more about sleep solutions besides medications after, but what are some common sleep medications that folks have found helpful?
Oh, such a great question. And I think part of why I wanted Dr. Barczyk on this call is because non-pharm really should be where we start, and really making sure people are doing everything they can in their power to get a good night's sleep before we get to medications. But that said, we do have a lot of options. From the over-the-counter standpoint, I feel like melatonin is one of the herbals that a lot of people do try at this point, which melatonin, Dr. Barczyk was talking about the circadian rhythm, and that's what our body naturally produces when the sun sets, and it tells essentially your brain that the sun is going down, it's time to start feeling sleepy, so you should think about getting ready for bed soon. And so melatonin is probably one of the number one, I'd say, herbal medications that's used. Fairly safe. It has not a lot of drug interactions. My biggest thing is, if you're using an herbal medication, make sure you're getting it from a quality source, because they are not actually regulated by the FDA like our prescription medications are. That said, we do have a lot of prescription medications at this point in time. The probably number one that's prescribed is known as Zolpidem. The brand name was Ambien. And I agree, at one point it was heavily marketed. That used to be targeted for just 7 to 10 nights of consistent use. And if you had insomnia longer than that, you should be looking for other causes of your sleep disturbance, which I think we're going to talk about before we wrap up. But that is a medication that I think a lot of people have tried. Does it help? Yes, but it's interesting when you look at a lot of the sleep medications we have, and they look at the patient's perspective versus if they put them in an actual sleep lab. A lot of times the patient who took the medication feels like they fell asleep faster and got more sleep, but the actual objective measures show that they maybe only fell asleep 5 to 7 minutes faster than the people who did not take the sleep medication. And so a lot of it is perspective, which is why, again, I think it's good to have a psychologist talking to us about this and really retraining the way we think about sleep and what our kind of realistic expectations are. The other, I'll say, off-label medication we see used a lot is called trazodone, which is actually an antidepressant. And we'll talk about insomnia being a symptom of depression if it's not being treated. So I do find it interesting that we use an antidepressant that has a lot of sedating properties at bedtime, sometimes to treat insomnia, but it's also probably helping with the depression as well. And then the other over-the-counter medication that I feel like a lot of people try is people buy like Tylenol PM or Motrin PM, which you need to know that that PM has diphenhydramine in it, which is our good old antihistamine we use for allergies and can be extremely sedating, yes, but it does come with a whole host of side effects. Especially older adults really should not be taking those medications because it's more likely to increase confusion. And really, those over-the-counter medications they're targeted at that short-term kind of acute stress that Dr. Barczyk was talking about, and not for chronic use, because really people grow tolerant to their effects. And if it worked for 1 or 2 nights, it's probably not going to keep working for a long period of time. So again, if you have a sleep complaint that's not getting better, you probably should talk to a doctor. So
that's good to know.
There's a lot more medicines, but I don't know if I have time to go into them.
That's helpful. That's a helpful place to start. And I think we definitely do want to encourage people, if you have this issue, you go find your doctor, your pharmacist, and you chat with them. But I think, I mean, I personally, don't have a PharmD and I see Tylenol PM. I think, oh, PM nighttime, this will help me sleep. Don't think much more past that. I imagine a lot of people find themselves in that boat. So that's helpful. Thank you. Dr. Ray Barczyk, I'd love to hear a little more about some sleep solutions besides medication that people
Yeah,
could.
absolutely. And this is the world I live in. I'm always trying to help people ferret out, medications versus the behavioral treatment. And of course, I've already said my bias there is the, medications to use PRN very selectively, not as a tool long term. Although it has to be said that there are, hundreds of thousands, maybe more, routine users of Zolpidem and other medications who report that they have no side effects that they notice. They think it's a good trade-off. I talk to these people. It's a challenge for me because my perspective would be that, well, you probably could be sleeping normally without the medication, and that you've normalized your sleep with a medication, but we could teach you to do it without, and then you'd have the benefit of better health, perhaps, and probably long term. But that's a tough bargain to make with people because they adopt if it's not broken, don't fix it philosophy, and I can see where they're coming from. So they like to believe, they do believe, and I don't believe that I don't really support this idea that their sleep system is broken somehow and cannot be fixed. Whereas the view of a cognitive behavioral therapist, and this gets into your question, is that we 99.99% of people with sleep problems have a fully operable normal sleep system that they've derailed through a series of intuitive decisions about, and then a loss of confidence about their sleep system because no one teaches them about it, and they don't get a message from the media and so forth, that this message that I'm trying to suggest, that you probably have a super healthy, usable sleep system, but you've cast it aside and replaced it with a medication. And of course, they try to go off the medications and they use the logic, well, look how bad my sleep was when I took a week off, because most people don't want to be on medications, and they'll try at the beginning of their dependency on it to go off. Unfortunately, they don't have their sleep manual to go along with that experiment, and they make the mistake of assuming the rebound insomnia that they get as they step down from their medications is a sampling of what their sleep would look like without the medication. I always try to tell them the muscle, if you think of it as a sleep muscle, the muscle gets very weak and depleted over time because it's not being used. Instead, the medication is creating an artificial falling asleep process, and that you need to re-strengthen that muscle. So it's going to take a few weeks. It doesn't take very long, but it's going to take a few weeks to fix it. So how do we do it? Well, it's very simple. It's the best treatment, I argue, and many others, that psychologists have ever developed. And that includes depression and everything else. And the reason why we say that is because it's so simple and works with such a high percentage of people. And the fix is almost always permanent, 80% of the time. If you can fix it in the short term, you'll keep those benefits long term. So it's really a phenomenal treatment. And it's so good and simple that it's now migrated into the online self-directed space. There's some amazing companies are jumping in like crazy now we've got about 10 new competing products, and one already got FDA approval and can be prescribed by your doc. And that's I love these products, and a few people have consulted with me. I almost got in on one of the design teams, and I was too busy and stepped away. But I'm a big believer, because that's going to help a portion of the population and be easy to access. So what do these treatments do? Well, first of all, they have you monitor your sleep very closely. So there's lots of freebies online to monitor your sleep, and recording a diary, not the watch kind. I don't think that's going to serve you as well, but a diary. So we start by monitoring sleep, and then we compress sleep. This goes back to what I was saying earlier, that quality more important than quantity. And we really want to break through the conditioned anxiety and arousal that's centered around the falling asleep process for people with chronic insomnia. So we want to make them triply tired for a short period of time that we call boot camp, by shortening their sleep and having them learn to fall asleep and stay asleep, even though it's a very short period of time. That relearning, that strengthening of the muscle is vital to the turnaround that then happens. And so we've short them on sleep, and we gradually add sleep back as they strengthen that muscle over time. And then we eventually, over 3 or 4 or 5 weeks, get them to a space of sleep. We call it their sleep window. That's going to be about 7.5 hours, like I was saying earlier. And they're going to feel ultra refreshed if they've been, impaired with their sleep for many years. And they usually say, that's it. I love it. I love having a long day and a long weekend days and going to bed later and getting great quality sleep. I think I'm going to stay with this window I've got now. So that's kind of how it works. There's a lot of, you can see from what I've been talking about, there's a lot of psychology involved. You got to change the mindset of folks and help them understand a lot of nuances about sleep, so they don't get caught up in myths that their sleep system is broken, being the number one, and that, there's something wrong with my sleep. I need, artificial ingredients to make it work. So there you go. That's my basic nutshell.
Well, and again, I think, oh, go ahead,
Happy
sorry.
to expand on that as needed.
Yes. And I think it goes back to, like I said, I remember I was a pharmacy student when Ambien was FDA approved, and insurance companies did not cover more than 7 or 14 days because it was originally intended for short-term use. And now as a pharmacist, we see people get 1 tablet nightly every night for 30 days with 5 refills. And so it's telling you essentially, as the consumer, this medication is supposed to be taken every night, even though it's really only if you have a hard time falling asleep that single night. So I think part of it is for us to kind of retrain our physicians and our prescribers how to, I'll say, use this medication sparingly and not as like a chronic treatment, and have the resources to get them plugged into rethinking about sleep. But I think Magdalene probably has another question for us at this point.
Oh, that was great. I really like the visual of the strengthening your sleep muscle. I had never thought of it that way, but that makes a lot of sense. So we've kind of, talked briefly about insomnia, and we've touched a little bit on the fact that it's a sleep disorder, but what are some of those other common sleep disorders, and can you really solve all of them this way? I'll let both of you take a crack at that.
I think my first, because I mentioned that short-term use, really I work in the psychiatry space. So insomnia can be a presenting complaint of other disorders such as depression or anxiety. So we want to make sure that we are treating the primary psychiatric condition and not just a symptom of the condition. So that's some of the psychiatric, I'd say, illnesses. We also see bipolar disorder, where people can go multiple nights without sleep and feel great because they don't need the sleep, which is a whole different, I think, thing that we need to think about treating. But in the sleep disorder space, I think when a lot of people have a sleep complaint, we were hoping to get a physician today here to talk about sleep studies. But really, one of the first things we should be doing is referring people to get a sleep study to see if they have that broken, fragmented sleep that Dr. Barczyk was talking about. Because a lot of our population may have something like obstructive sleep apnea, where the common thing I think we think of is snoring, where your bed partner's snoring and they may be actually kind of gasping for air in the middle of the night because they like had a hard time getting the air through because they have that obstructive sleep apnea. And so again, that's another treatment that's going to be completely non-pharmacologic. They need to treat the sleep apnea with a breathing device such as your CPAP machine rather than medications. And so again, I think part of it is diving down as to what's causing their sleep complaint, because they feel tired because they're not getting good sleep, and giving them a medication to help them fall asleep is not going to treat that underlying condition. Some other interesting ones are narcolepsy, where we talked about REM and non-REM sleep. People with narcolepsy actually go straight into deep sleep, into the REM, which is amazing. It's extremely rare condition, but something I'd say privilege of meeting a few people with over the years. And restless leg syndrome is the other one that I feel like I've had a lot of people talk about lately, where they lay down in bed and have that need to get up and walk because they feel like they have creepy crawly sensations in their leg. And again, that's going to be a totally different treatment than our typical medications that we use for insomnia. So I don't know if Dr. Barczyk wants to add to that, or.
Oh yeah, I'm gonna, I got something to say about everything. Yeah, so let's take it from the top. Start with, what you started on with mental health and sleep, and mental health problems and sleep. Yes, absolutely. I get people referred to me. I talk to people who have depression and have never tried an SSRI. And, that's the first thing I'm going to say. In addition to me working with you on your sleep, be sure to get this, consider a medication. It looks like you have the hallmarks of a, chronic low-level depression that will impact your sleep, no doubt. Anxiety, same thing. So, and we've got this great drug out there. This is one miracle drug that I, am happy to endorse and think is underutilized by some people, is the SSRIs. So there's that. But on the flip side, I've had patients come to me, and I know they're out there, who a doctor, in not understanding the sleep system, will, well-meaning, will try to explore and conjecture that their problem is caused by an underlying depression because they're not responding to the pills, and sleep center had nothing to offer. And so they come to me several years later with a good deal of resentment that they were started on all kinds of psychiatric medications because the sleep was the problem, and they really just needed, to have their sleep system adjusted and fixed and, put back into functioning. So there's that. Now, the other thing is sleep referrals for problems with sleep. Oddly enough, sleep centers are not a great place for garden variety sleep problems. Sorry to say, that's just a fact, and they will admit it as well, because they function on the only way they can stay in business is not to spend a lot of time educating people about garden variety sleep and how to improve sleep, do the behavioral stuff that I do. There's no business model out there that is going to allow a sleep center to stay in business if that's what they do. So they're really great at sleep apnea, which is an extremely common issue, and they're really great at narcolepsy and so on and so forth. The thing they're not good at all is, and they tell me that, they send me patients, is insomnia. So a lot of people go to sleep centers thinking, oh, gee, I need a study, and they get screened out of a study, and rightly so, because they don't have any of the risk factors for apnea. It's pretty easy for these places to spot risk factors and do a screening before, and the insurance companies won't let them do a test. And then if for some reason they have borderline risk factors and they get the sleep study, it can often serve as a distraction to people because the findings are always inconclusive. They didn't sleep well in the sleep lab. Maybe they did a home study, but that's a little different. That's mainly targeting sleep apnea. They come back to me saying, gee, I thought I was going to learn all this great stuff about my sleep. And rarely do people who have garden variety problems get some value out of a sleep study, I hate to say. But so there's those two things. But I agree wholeheartedly with Erika that we've got to get more people screened for apnea, and that can be an issue. And I know what I wanted to say, apnea is so common that there's a lot of people that have both apnea and insomnia, and that's a new target group for our treatments in behavioral health or cognitive behavioral treatment, because they've had reason for their sleep to be disrupted because of their apnea. Now that's been corrected, but in the meantime, they've undermined their whole sleep system before they got it treated, and now they can't put the genie back in the bottle because you need to do the stuff that we just talked about to get rid of the insomnia. And thankfully, my apnea docs in town are very savvy to this now, especially the VCU Sleep Center and other places. Thankfully, are saying, "Oh, wait a minute, you're complaining. I could see that from your sleep study, your CPAP is working great, but you're still complaining of poor sleep. That's because you have insomnia on top of your sleep apnea, and the two often go hand in hand." So I'll stop right there.
No, and I think since we brought up so much sleep apnea for the audience, just some screening, quick screening. If you have a history of snoring, if you have that daytime sleepiness, if your bed partner has actually observed you kind of choke or like stop breathing in your sleep, if you have a history of high blood pressure, people who are overweight, and sorry, Bruce, men who are over 50 are also at a higher risk. But you do not have a large neck. It's like your football player size, larger neck size. So just things to keep in mind. And I agree, we're also doing more studies with medications, because some medications can specifically worsen sleep apnea, such as the benzodiazepines, which were originally used for sleep, such as temazepam, which is Restoril. And so we are actually starting to do studies of medications to see whether or not they're safe in patients who have sleep apnea, because ultimately we don't want to worsen those apneic episodes. So great discussion.
Yeah, very good discussion. And there's newer treatments for apnea. Now, sometimes apnea is overdiagnosed and overtreated. So that's another issue. There's people that need the treatment out there, but sometimes well-meaning but aggressive treatment of apnea can be frustrating for people that are, where it's not really, they only have mild, and it could be alleviated with better sleep positioning and certainly better sleep. So I would throw that caveat in there as well.
Yeah. And Dr. Krause, that leads us right to my next question. You mentioned a few meds you probably should be aware of if you have sleep apnea. Are there any others that interfere with sleep apnea or other disorders? Any other medications that could interfere with that?
I could worsen sleep. I'm going to start with a non-med, because when I do sleep groups, I feel like a lot of people use alcohol and assume it's a CNS depressant. They feel tired, they're more likely to fall asleep. But the thing is, it's not that good restorative sleep. They actually kind of miss that, and they're more likely to wake up at maybe 3 or 4 o'clock in the morning and have a hard time going back to sleep. So definitely not something we recommend. And alcohol also can interact with a lot of the sleep medications because it causes that additive CNS depressant effect. And some people can have kind of like a hangover effect the next morning, which we don't want to see. But thinking about other medications, things we can do. We've been talking a little bit about depression today and antidepressants. Some of the antidepressants, ironically, even though they're treating depression, where insomnia can be a symptom of depression, a side effect of a lot of our antidepressants can be insomnia. So we might want to ask somebody, what time of day are you taking your antidepressant? If they're taking it before bed, we might switch it to the morning. A medication called Wellbutrin or bupropion, we try not to take the second dose after about 2 or 3 o'clock in the afternoon, because that can worsen their sleep. Some people who are on different blood pressure medications, especially the diuretics, we don't want to take too close to bedtime, because we don't want somebody to get up and have to pee in the middle of the night, because that can also impact your sleep. And I'd say my other just big one is caffeine. Some of the most impressive interventions I've made on patients who have sleep complaints is have a discussion about how much coffee they're drinking. And they tell me, oh, my last cup is after dinner, and then they have a hard time going to sleep. So sometimes teaching them, again, those non-farm, when should you have your last cup of coffee, would be a good intervention before we start them on a sleep medication. So
Definitely. I know I have to kind of limit my caffeine as well. I try to avoid it in the afternoon for just that reason. Kind of backtracking just a little bit. If you've gone through all these things, you're optimizing your sleep, you fixed your sleep cycles up, and you're doing well. What are some of the health benefits that we can get from having enough sleep? I'm sure there's a range. So either of you, feel free to take a stab at that.
I know Bruce will have a lot to say, so I'll take a quick nugget. I think just number one, you feel better. You're more refreshed during the day. Usually your focus is better if you get a good night's sleep. I think it can also impact your just overall wellness, mental health, physical well-being. And then, as we mentioned, I think it lowers the risk of some of the cardiovascular and metabolic disorders if you get good sleep. So I think of sleep as like recharging your battery. Your cell phone's dead if you don't plug it in overnight. Same thing, you need to get in bed, recharge, so that you can function really well the next day. So it is important. And my last comment is, I'm a professor, and I always love the students who did not do well on an exam and come and tell me they pulled an all-nighter. And I'm like, well, you never really made memories of everything you studied, because you need to take the time to get into those sleep cycles so that you can make new memories. So I think sleep is really important before an exam as well. But I'm sure I'll turn it over to Dr. Ray Barczyk on that for some additional benefits.
Okay, yeah, let's see. Now, I want to make sure we touch on a couple of other things because we're finished at one, right? We're getting down to the wire, and we got this nice list. We're almost to the bottom, but a couple of things. So maybe, if okay with you guys, I'll pivot to sleep and aging, because I think Erika covered the other stuff really nicely. So one of the things that I might disagree a little bit with that Erika said earlier is older adults needing less sleep. I would say the correct way to frame that is that older adults get less sleep on average, and they get used to it. And it's harder to achieve the same quantity of sleep earlier in life, for sure, but the sleep need is probably the same, and that's why a lot of older people are not satisfied with their sleep when you measure it on a whole, because they're not. So a lot of the behavioral stuff that we can say it like this, that in the sleep muscle, just like any muscle in the body, is not as strong. The capacity, the optimization is not as high, the optimal level of functioning. So like the people in physiological health argue, aging is a time when exercise is even more important. We tend to associate it with younger people because body image stuff is important to younger people and they really focus on it. But later in life, fitness and muscle strength is really vulnerable and needs more attention and more routine and so forth. So the same is true with sleep. Your system, your circadian system, it doesn't have the same amplitude. And so you need to practice better sleep habits that maybe earlier in life. You mentioned college students in their 20s and so forth. yeah, their amplitude of their circadian system is super high in that decade, and they can beat their sleep with a hammer and do those variations you said on weekends and so forth, and they're fine. It's not really affecting them, and they can make those adjustments weekdays to weekends, and they see no consequences, so they just forge ahead with that. And of course, some of them develop insomnia and really have severe problems. But the problems with the everyday problems are more common later in life. And that means learning more about sleep and practicing and using the techniques I've talked about, especially if somebody increasingly uses medications. And usually this decline starts in your 50s, 60s, and then 70s. So of the amplitude of the sleep system. So I get a lot of people that started tampering with meds who slept fine up till age 55. And now they're having cracks in their system, and they start drifting towards a medication solution that maybe they used to use once in a properly, PRN, once in a great while, when they had. And so I think that group I'm very interested in getting education out there. So I'm glad I had this chance to say that. And I see you have something to say, Erika.
I do, before we wrap up. And the main reason is we didn't really get to talk about side effects of meds, but the older adults specifically are so sensitive to the side effects of our sleep medications. And we really, really need to be concerned about them getting up, being dizzy, falling. They've been linked to increased like hip fractures in our older adults. And if you read older adult guidelines, they really don't recommend anything, maybe melatonin, but most of the medications we use for sleep, the side effects that often outweigh the benefits in our older adults, which is very interesting. And just in our general population, because we didn't talk about it, people who take a medication for sleep right at bedtime, they really need that 8 hours in bed before they get up and do something that requires their mental alertness, because there have been a lot of reports out there of increased on the job injuries, or even, I hate to say, DUIs, driving under the influence, because they have not given time for the sleep medication to get out of their system before they do something that requires mental alertness. Sorry, I almost said mental illness. But I think if we are using those medications, it's imperative that we educate people about the proper use of them so that they can minimize some of those side effects. But there's not a great answer for older adults. So thank you.
Yeah, those are some great things for us to consider. And we just have the 2 minutes left, so I do want to hear any final thoughts either of you have. Thank you so much again for this great discussion. I think we've learned a lot today.
Yeah, I think this is a great idea to have this dialogue between pharmacy and psychology about how to balance the right use of medications and so forth. The thing I'll add that Erika was just talking about as a final thought is, yeah, there's a lot of older people who have physicians. Typically, it's a newer trained physician who are extremely reluctant to give them a routine dose of Ambien for the very reasons that Erika was talking about. And there's fights going on out there, by my father being one of them, with their primary care doctors constantly now, especially the newer ones that have been trained to be very mindful and cautious. And so it's a tough call, because some of these folks, like I said, will argue that, hey, it really worked for me. But I'm more comfortable if they're going to try I'd love to have them all try a behavioral treatment to see if we can fix. And that's why I want to see a large scale rollout of online treatments and more providers. And I hope the day comes, because we've failed to train up enough clinicians. And so that's maybe my closing thought.
I just want to say thank you. It's always a great topic to talk about. So thank you for having us today.
Yes, thank you very much. I love having opportunity to reveal the secrets of sleep.
Yes, thank you all so much. And we are right at the top of the hour, as the calendar just indicated for us. So thank you both again for being with us today. And thank you to our audience for tuning in. Have a happy holidays, and we'll see you in the new year.